Turn me up just a little bit. Yeah, it's that man space vibe. Step in the zone, microphone check. Russ and Les got the real intellect. Talk smooth like jazz on a late night set. With a convo deep and the topics connect. From the struggles to the wins, they address it with grace. Drop lines so cool, you can feel the bass. Two kings of the craft, and you know the rest. Kick back, pour a drink, welcome to the space. You go chillin' with Russ and Les. You go chillin' with Russ and Les. You go chillin' with Russ and Les. Hang out, cause now you vibing with nothing but the best. Space forever.
Welcome into another edition of the Manspace Podcast. And it is the Russ and Company series where I interview some of the most amazing people from all around the world. And yet today is no different. Now, we have been fortunate to interview some guests in all types of fields. And I will say for the first time ever, I'm going to interview an actual dentist on this show. Now, guys, you might be saying, why? Why would we do that? Well, one thing that we all want is to have a beautiful smile. We want to protect our teeth. We don't want to have to pull them out. So let's talk about that with our guest today, Dr. Edward Feinberg. Dr. Feinberg, welcome into the show.
Thank you. It's an honor to be here. I'm great. And you?
Fantastic. So let's just talk about you for just a moment. And what was it that said, hey, this is the field that I want to go in. I want to get into dentistry.
Well, I grew up in dentistry. My dad was a master and pioneer of full mouth reconstruction and crown and bridge dentistry. He was a genius who was way ahead of his time. And so I grew up in it. And so there was really no question what direction I was going to be going in, because I had such a unique opportunity. Almost nobody that I know gets an opportunity to really study with a master in any field. And I was born into it.
Wow. Now, do you have siblings as well?
No, not anymore. I did have a sister who passed away, unfortunately. But she wasn't oriented toward dentistry. So I was the only one in the family who was oriented toward dentistry. And I started working with my dad in the office when I was a teenager. And I always had a job. I was in the family business. So that was wonderful. And I was trained completely differently from everybody else. Because my father was so way ahead of his time. What I was taught is completely different from what's being taught in the dental schools. And I have to watch them all having difficulties with problems that were actually solved in the 1930s. So you think we're advancing in the field? That's what I've had to deal with for my career. And so it's very hard to watch my area of dentistry go backwards while a lot of other areas are actually moving forwards.
So your area is more into the crown and bridge work and implant, things of that nature. Kind of explain that side of it rather than just the normal dentist that somebody would go in to see.
Well, there are really two different approaches, I think, to dental care. One is what I would call a piecemeal approach, where it only involves filling a hole or a space. And the other approach is an overall approach, which looks at the problems that a patient is having and what can you do to prevent that patient from having disease and ultimately losing their teeth. So I was trained with an overall approach to dentistry. And crown and bridge, when done properly, is corrective in that you can change the architecture of the mouth so that the forces are balanced properly on the supporting structures and the patient has a chance to maintain it. A lot of dentists only think of crown and bridge as nothing more than tooth coverings, and nothing could be further from the truth. So now what I see is the absolute signature of a piecemeal approach to dentistry is the single tooth implant. And the reason I say that is, and sometimes piecemeal is not a bad thing. I don't want anyone to get that idea that it's always bad to do piecemeal. So let's say a person had a perfect mouth with no periodontal bone loss and no fillings, no crowns, and they were missing a tooth. That is a perfect place for an implant. That's piecemeal, but it's a perfect place for an implant. But that is not what you see when you go to the lectures and when you go to see the presentations in dentistry. What you see is all the teeth around the space have crowns on it or big fillings or are going to need crowns or periodontal bone loss. And so that is not a virginal mouth. That patient would be better off with good crown and bridge, which can do something good for the whole area and change the architecture of the whole area to prevent disease. Whereas the implant just fills the space and does nothing for the teeth around it, and the patient's problems are never solved. In fact, it's quite common for patients to end up with a hodgepodge of treatments and nothing relates to each other. And that is that's what I see, because there's less and less dentists who know how to do good crown and bridge, but there are a lot of dentists who know how to do good implants. And so, especially young professionals, they only want to do implants because somehow they have this idea that it's more lucrative than crown and bridge. And that's not true. And I think another factor is that the techniques that they're being taught actually violate the basic principles that allowed me and my dad and my dad's teacher to have so much success. So they don't have confidence in their crown and bridge techniques, and they would rather pull the teeth out and put implants in, because a lot of people can do good implants.
Now, you mentioned periodontal bone loss. Can you explain what that is and how can people prevent that?
Oh, that's a very good question. Well, when I talk about periodontal bone loss or the bone, I'm talking about the bone specifically around the roots of the teeth. The teeth are connected to the bone by a ligament. And the way people get into trouble with losing their teeth is generally if something happens to the bone. And we don't know how to grow it back. So everything we do in dentistry is geared toward preventing the bone from being lost. Because once it's lost, eventually the patient will lose their teeth. And that can also happen around implants too. So you want to do everything you can to prevent that from happening. So the number one thing that contributes to periodontal bone loss is letting tartar and plaque and calculus build up, because that can cause the gums to become inflamed, and that can spread to the underlying bone. So the single best thing that anybody can do for their oral health is to have regular hygiene at their dentist, and also maintain their own hygiene at home. It's the single best thing. Then there are other causes of periodontal bone loss as well. Some causes we have no control over and don't fully understand, like certain systemic diseases like diabetes, cancer, heart disease can affect the bone in ways that we don't fully understand. And also there are certain genetic conditions, but those are in the minority. I think one of the main causes of bone loss is missing teeth, especially in the back of the mouth, because what happens is when teeth are missing, the teeth around the spaces tend to drift, and then the teeth opposite the spaces that tend to erupt into the spaces, and then the teeth start to take forces in abnormal directions, and nobody knows when the body's not going to tolerate that. And when it can't, one of two things happens: either the bone disappears, or the teeth wear. Those are the two things that go wrong in human beings. And so that's why it's so important to replace missing teeth to prevent that from happening. So a good analogy would be the arches that the Romans built. They built these stone arches that carried water for large distances. And the stones were buttressed against each other without cement. But if you were to pull out one of those stones, the entire thing would collapse. And that is exactly what happens in the mouth, because the teeth are formed in an arch as well.
Wow. So you mentioned earlier about trying to save teeth rather than do implants. Why is that important?
Oh, yes. Wouldn't you rather save your own teeth than put something and stick it in the bone? It's a foreign body that you're putting in the bone. And so all day long, your own teeth are better and a better prognosis. People have this idea that implants are forever and that it's going to be the end of all their problems. Nothing could be further from the truth. That is not true. Implants are not lifetime. I've had the patients where they only lasted 20 years and that was it. And then a lot of times they can't have further implants. There's some things being done now that I'm against. One of those things is what they call all on four, where they pull out the teeth, all the teeth in an arch, and then they put 4 implants, usually 2 in the front and 2 in the back. And if they can't put good long ones in, they're putting back a superstructure on these implants that not only replaces the missing teeth, but the missing gum and bone as well. And these implants are overloaded, and they're feats of engineering. So you cannot overload any engineering structure or you're going to have an engineering disaster. And when that happens, even if one of those implants goes, that patient is screwed, because they may not be able to have any more implants, and the ridges have been flattened. So now they can't even wear a denture. So I'm against this. I think there are better ways of doing things that take into account the forces that are going to be acting on these implants. And a lot of people don't realize that. And there's no way for most patients to really understand what it is they're getting. And they should make sure that they do their homework and not be so quick to pull out all their teeth and place implants all over the place. They are not the panaceas that people think they are.
Yeah. Wow.
However, on the other hand,
sure,
I've done a lot of crown and bridge. I have 70 years of documented evidence, more than 100,000 pictures of cases that go back to 1950. All the teeth prepared and handled the same way, and the cases followed for decades with x-rays. When you look at x-rays of cases that I have done, that my dad has done, you could see that it looks like the crowns are almost sitting on the bone. That is the best architecture that you can have for health. I break my neck to make ideal architecture, to make the teeth smaller, to put the least of stress on the supporting structures, which is the bone and the roots. And then I follow up the cases year after year after year. And what I want to see is that there are little or no changes. And I have a lot of cases where the patients had systemic conditions like diabetes, heart disease, cancer, where you don't expect anything would work. And it held up in spite of that. I don't see any dentists at any of the presentations showing any follow-up. They show how pretty the case looks on the day of insertion. But what good is that if it doesn't hold up? So I have dentistry in the mouth that I did in the mouth 40 years with very few changes. And that is what I want for my patients, that I did something that enabled them to hold on to their teeth and that they don't have to spend their whole lives in dental chairs.
There is a substance that is being used in some toothpaste. I think it's called hydroxyapatite.
Yeah, that's supposed to be help remineralize enamel. You know, for where enamel might be lost through some kind of defect or
Mhm.
I don't know how well that really works. I'm not a big fan of toothpastes as the answer to
Mm,
things. The real
mm,
importance of toothbrushing is mechanical. That is to not only remove the plaque and calculus, but also to stimulate the gums so that you
mhm,
get good circulation and you could have nice, healthy gums. That's really the
mm,
purpose of toothbrushing. And it's the action of the toothbrush that's most important, not the toothpaste. And I'm also not a
mm,
big fan of mouthwashes either.
mhm. Hmm. Now, why is that? Uh, as far as the mouthwashes, why are you not a fan?
Well, I there are occasions where mouthwashes can be helpful. A lot of them have
Mhm,
alcohol in them, which can have a very drying
mhm.
effect on the
Yeah,
on the gingiva, which I don't think is so great. There are some
right.
mouthwashes that have fluoride in them, which I think have worked
Mhm,
really well. They're antibacterial. But now there's this whole thing about fluoride and like people are
right.
worried that we're trying to poison them and all this stuff. So there are some other ways of doing things that you don't have to rely heavily on mouthwashes. So
Mm. So I
this
that's
would
something I
be
hope you share with. Yeah, I'm curious. I love for you to share some of those other ways, other techniques.
well, one of the things that I talked about was crown and bridge. When you create a healthy
Mhm,
architecture, that the
mhm,
patient can maintain their teeth easily. So if you have areas where food impaction is, let's say
mhm,
food is packing in, that's the kiss of death. That can cause bone loss faster than anything else. So you correct
mm,
all those things. So one of the things that we do is I try to make the teeth smaller, bring the teeth closer to the supporting structures, which is the bone and the roots. And very often we
mhm,
tie them together so we not only prevent food impaction, but we also help distribute the load among a group of teeth so that each tooth doesn't have to carry the load all by itself. So that's the
mm,
purpose of doing dentistry, to make it easier for the patients to maintain their teeth and gums.
mm.
So everything kind of goes hand in hand. So when I
Yeah,
prepare a mouth for crown and bridge work, I prepare the teeth in a different way than what's being taught. It's a three-dimensional approach where you prepare the
okay.
tooth, the gingiva, and the bone at the same time if necessary, so that everything
Mhm,
relates to each other in an ideal way. That is not taught.
mm,
And
mm,
the evidence is overwhelming that I'm on the right track because you are creating a healthy architecture and preparing the mouth to receive the dentistry so that everything
mhm,
is ideal from the start. So if a patient had bone loss and faulty architecture, you've now
mhm,
created the most ideal situation for that patient that patient could have. So you are compensating for bone loss to prevent future bone loss. So that's what I do
mhm.
that's different.
So I feel like I have to ask this question, and I think there are a lot of our listeners out there that are looking into getting veneers or have veneers. Wanted to get your professional opinion when it comes to getting veneers and wearing those.
Okay, that's a very good question. I think veneers are for young people and should be confined to the front six teeth. And the reason is if you prepare teeth for crowns on a young person, you're more likely
Mhm,
to get involved in with root canal therapy because the nerves are much larger. As you get
mhm,
older, the nerves shrink down. One of the problems with veneers is that you can't help but make them bigger because they really only bond to the enamel layer. And you can't take that much off that what you're putting back isn't bigger. A young
mhm,
person is going to be able to tolerate that. As you get older, the body can tolerate less. So as a person
mhm,
gets older, they should have crowns because you can make the teeth with ideal architecture, ideal shape and size, and you're not
mhm,
limited to the little amount of tooth structure that you could take off. the enamel with crowns. So it's a whole different approach. Every person who has veneers should understand that they are committed to doing crowns one day, because the tooth structure has been irreversibly cut. And at a certain point, that will no longer be the correct treatment. And I doubt a lot of them are being told that, because dentistry is not lifetime. And there's a point at which it should be replaced. And sometimes it can be a tough call if the changes are minimal and gradual rather than drastic or happening all at once. And so that's the problem, but they should all understand that. So a young person could have something which vastly improves their appearance, but later on they'll have crowns, and then they'll be in a better position to have crowns as they get older.
So can you explain crowns kind of at a high level? Because what I keep envisioning every time you say it is the old silver cap that would go all the way over the tooth. And we used to see the old moms and grandmas that had the tooth in the back that was completely silver.
The reason is that they don't go down far enough under the gum. And so you see the margins, or the dentistry's old and there have been changes and now some of the margins are exposed. That's an indication that maybe dentistry should be replaced. But generally, and when you prepare a tooth for a crown, you generally put a ledge on the tooth structure all the way around. Now, what they're doing is something what's called butt joint dentistry. And that is that comes from carpentry. And that is where you make the crown to the ledge. Those crowns can never be sealed because bacteria are 2 to 10 microns in size. And the best marginal adaptation that we can get with all our terrible indirect techniques is 80 to 120 microns. That might as well be the Grand Canyon. So the problem with butt joint dentistry is that you can never seal them. And it's unrealistic to think that the bonding crap's going to seal everything up. You can't see at that level what's sealed and what's not sealed. And one of the problems with bonding materials is that it's very sensitive to moisture. And where is the moisture? At the margin. And so that is the problem with that. This has been known at least since the 1960s, when we baked porcelain crowns in an oven and they were baked to the ledge. You think we didn't know what was wrong with those things? So now you think we're having advanced technology, crowns in an hour, and they're going to mill a crown out of a block of ceramic. What do you think that is? It's the same butt joint crown, except it was milled out of a block of ceramic instead of baked in an oven. It's the exact same thing, and most dentists don't know that. By contrast, I make crowns on the model of the mason jar cover, which is the best known thing ever devised for food preservation. So the margin goes over the ledge all the way down close to the bone. So I get good retention on my crowns and bridges, that they won't fall out if I put nothing in them. In fact, I let the patients wear them on a trial basis with rubber or Vaseline, and they do not fall out. And then they are sealed like a mason jar cover, so I almost never get decay under them. My dad's teacher did that. That comes from dentistry's roots, and the profession has forgotten where dentistry came from. The teachers teaching in the dental schools have no idea where dentistry came from, and they're teaching techniques that violate the basic principles that allowed me and my dad and my dad's teacher to have such phenomenal success. I have dentistry in the mouth that I did in the mouth 40 years, and not many people can say that. And I got to show them the x-rays too. Not many people can say that. And that's the reason. And there's less and less dentists who can do that, especially the younger practitioners who think they know everything because they know how to use a computer. And this is basic principles that has nothing to do with computers or digital or analog. Basic principles are always the same and apply to both digital and analog techniques.
Let me ask you this. Why do you think that so many people are afraid to go to the dentist on a regular basis? And then second part to this question is, what is one of the biggest misconceptions that you feel people believe about dentistry?
Well, I think a lot of people have been traumatized. Maybe a dentist
Mhm,
hurt them. I was amazed because I grew up in dentistry. My dad always used local anesthesia, and he never worked on
mhm,
patients if they felt it. And he said, Even if they say it's okay, it is not okay. They'll never
yeah,
forget that they sat there and had to endure pain. I'd rather send patients home than have them, be uncomfortable because I would sit there for that. So you have to handle patients with care, and
mhm,
that's that. It was always around, but especially on younger patients, because I mentioned that the nerves are much larger. They need the anesthesia even more. So if
mhm,
they're a child and the dentist doesn't use enough local anesthetic or doesn't take care to make sure they don't feel anything, they're going to be
mhm,
traumatized because they're going to
yeah,
feel it much, much more readily than an adult would because the nerves are so much larger. And so
mhm,
that's not fair at all, in my opinion. So that's what I think happened to many people because you want to make dentistry pleasant, that it shouldn't be an ordeal, that they shouldn't have to sit in the chair for long hours. They shouldn't have bad experiences. I bend over backwards to make sure that their temporaries aren't going to fall out, and that
mhm,
they don't have to worry about having problems in between appointments. Um, and that's uh, that's I do the best I can. And I think
yeah,
if you go and bend over backwards to give the patients a little extra TLC, you got sometimes you got to make them a patient after the trauma that they've
yeah,
had, and some of them neglect themselves because they feel they've been hurt and they're afraid of being hurt. I think that's one big problem that we have,
mhm.
and I
Wow.
get it. I understand.
Yeah, that opened up your response just opened up a wound for me because I remember being my last days in the military, uh I had to get my wisdom teeth removed. And so I had all four of my wisdom teeth. They went in, they took one out because I was having problems with it. It was coming through the gums. So they took that one out first and then they scheduled an appointment to do the others because the others were still impacted. So they make you sign this waiver that said, you can't sue because there is a possibility of paralysis if they hit a nerve or something like that. And we couldn't sue the military for it. I'm like, okay. So I signed this waiver and I'm awake the whole time, local anesthetic. And so they go through, they get the first one out, they're working on the second one, and I can hear everything. And it's just the sound. And it was so traumatizing hearing that sound. But then when they finally got ready to get it, I felt a twinge shoot from my jaw all the way up to my ear. And I said, nope, I'm done. And they said, oh, we can give you some more. Nope, I don't want any more. I'm done. So to this day, I still have one of my wisdom teeth in my mouth. And that was over 20 years ago. But I still have this one in my mouth. And I just like, I could not, I couldn't go back and go back and do it anymore. It was too traumatizing for me. So anytime
Well, that
I've had to deal with oral surgery, it bothers me.
the good oral surgeons, they have much better techniques of handling patients. This is not my area of expertise.
Yeah.
Um,
Yeah.
but uh, but I don't know, who is doing your particular surgery, but I think in general, most of the oral surgeons I've met can handle people and they use a little conscious
Mhm,
sedation,
mhm,
and make it work. I had major eye surgery and use
mhm,
conscious sedation and local anesthetic, and I didn't have a
mhm,
problem with that. But I also had my own wisdom teeth out with just local anesthesia, so I heard the
mhm.
noises, I heard all of that stuff. But
Yeah.
it didn't bother me much. I didn't really feel anything. And once in a while, there are different branches of a nerve that might not have. gotten the anesthesia or might require a different type of injection. And so those things can happen. It's how they're managed that's important. And so that's the best I could tell you.
So in your area, in your area,
go ahead.
You have the opportunity to basically say, "Hey, I'm better than these other dentists out there. Come to me. I'll treat you and bring in more and more patients, right? With your techniques, and how you do things. Why do you go about trying to help spread the word to help other dentists get better when you could actually easily just say, "Hey, I'm better," and get these patients into you and make the bigger profit? Why do you go out and try to help others?
Well, first of all, I don't like that idea that somebody sets themselves up and say, "Oh, I'm better." First,
Right.
That's not what somebody in a learned profession would do. My job not only is to be a good dentist, but to make the profession of dentistry great. And I think we have a duty to spread knowledge and help other people. So, especially at this point in my career, my focus is I want to help others be able to do better dentistry. So I have a teaching website with 35 courses on them, teaching dentists how to do this kind of dentistry. I'm publishing my third book, which is my second textbook. I'm in the process of that, which describes all these techniques in great detail. But I also take a lot of continuing education courses. I don't know everything or pretend to, so I would never set myself up that way. I have a lot of answers to restorative problems. I have some better answers than what's being done to people out there. But I go and take a lot of continuing education courses, not just to learn something new, but also to see what they're doing, even if I don't agree with it. So that's how I look at it. I'm a lone voice screaming into the wind, and I'm an outsider, meaning I'm not from any dental institution, a dental school or one of the major dental institutes in the country. That automatically puts me in a category that's like outsiders need not apply. You think those political institutions are very embracing of people like me? They're not. And it's very hard for me to get on academic stages. Even though I can show cases in the mouth over decades with x-rays, and there's almost no one else who can do that. Very few. And I would say there are less who show that now at this stage of my career than they were at the beginning of my career. Think about that and think about, are we advancing? So most of the time, all they show is how pretty the case looks on the day of insertion. What does that mean? To me, it means nothing, because if it looks pretty but doesn't hold up, is that something you want to do? I don't think so.
Yeah, I love that answer, and I love how you put it, that you don't know everything and you're continuing to learn and educate yourself in the process. So with that said, where do you think the future of dentistry is going to?
Well, I worry about the future of dentistry. And the thing I worry about most are attitudes, because I've seen a tremendous change over the course of my career. So I was raised in dentistry to focus on health and longevity. That is what my major focus is. That's what I got from my dad, and that's what he got from his teacher. What the focus I see now for most practitioners is economics and workflow. And that is not the same thing. And so a lot of people, they put something in and they don't worry about what happens to the patient down the road.
Right.
Whereas what does it for me is I get to see my patient come in year after year for their hygiene visit and watch the work that I did last in health year after year. Then you did something good for that patient. You beat disease. You enable them to hold on to their teeth. It's not normal for you to lose your teeth. God intended that you would hold on to them for your lifetime. And so if you can do something to make that happen, then you are doing a tremendous service for the patient. Now, if that being said, dentistry is not lifetime, and that includes crown and bridge. And what determines whether dentistry should be remade is changes that occur. And for everyone, it's different. So I have some patients, like I mentioned, with dentistry in the mouth 40 years. The changes are minimal and gradual, so they got away without having to replace the dentistry. But other patients, after 10 or 15 years, the dentistry should be replaced to compensate for the changes. And it can be a tough call as to when you should step in and do that. So that is the basics in a nutshell. So it's important when I have a patient, I want to keep them as patients and watch how everything holds up year after year and step in, because if the teeth are in good shape that you could make a new case, that's a success.
Now, you mentioned your third book that you're working on, which is a textbook. What are your other two books, and what are the titles of them?
Oh, good question. My very first book was a textbook on a very niche subject in dentistry called the double tilt precision attachment case. And this is a type of removable partial denture. Let's say if you don't have enough teeth to make fixed bridge work. And it was a different kind of removable from everything out there, because every single type of removable partial, especially the class partials, put lateral destructive forces on the teeth. And the history of a class partial, for example, when you see somebody walking around with the hooks on the removable and their hooks, is that it acts like an orthodontic appliance and moves the teeth back and forth, back and forth, back and forth. And the history of those is that they're transitory to a denture. So as the teeth that hold the clasps are lost, you move the clasp up to the next tooth. So they're transitory to a denture. The double tilt precision attachment case, which was invented in 1906, doesn't function that way. See, nobody knows where dentistry came from. And it's basically the attachment is a male-female that functions vertically. And the way it stays in is very ingenious. The angle of how you take the partial in and out is tilted in two directions. And this direction is different from the pull of the muscles and gravity. So if a stress is applied to it, it can move slightly to relieve the stress, but it can't come out. Those work on the worst teeth you ever saw. It has the best track record for longevity of any kind of case in dentistry. And it works great with implants. One of the problems with implants is that they're being extended beyond what they're designed for to make fixed bridge work. But I could put 3 implants in the front where the bone is good, and I could put 3 good long ones in, make a fixed bridge and this case, and stay away from all of the bad anatomy with sinuses or hollow cavities and bone grafts and the bone missing above the nerve on the lower. I could stay away from all of those things, and no one will listen. They won't listen.
Wow.
They are brainwashed in a certain way of thinking, and it's almost impossible to get them to look at things from a different perspective. So the problem with implants is that they're being extended because there's this misconception that fixed bridge work is the answer to every restorative problem, and that's not true. So what I tell my colleagues is that if you know how to make good precision attachment case, if you know how to do good implants, if you know how to do good fixed bridge work on natural teeth, then you could pick and choose what's really best for each patient, because there is no one size fits all. And you have to ask yourself questions. If you had what the patient had, would you want that for yourself? I think that's a very good yardstick. I don't think enough practitioners are asking those questions. And they're putting through patients through a lot of invasive treatments. And I don't think it's right.
Right.
You can tell I'm very opinionated.
So for you are in the Phoenix area. How can people find you, find your practice, follow, and then, we have a worldwide audience. There may be people that want to, get more information. You even mentioned, your classes. How can people find that information out there?
Oh, sure. My teaching website is www.theonward program, ONWARD program, theonwardprogram.com.
Mm.
And you don't need to be a dentist to go there. You don't need to be a dentist to take the courses. I tell all my colleagues, if they want to have the courses for nothing, I'll give them a special code. They can have them all for nothing. I only care that they get the material. And there's a documents library. I also write a monthly blog on different issues in the profession. So if they want to be on the mailing list, they don't have to be a dentist for any of that. I just hope to get the information out there. And I'm very easy to get a hold of through my teaching website.
Awesome. Awesome. So we like to close out with one last thing, in which we love to call the last word.
And now, the last word.
So we have a lot of young people who do listen to this show as well. And there might be some who are teetering toward wanting to get into the field of dentistry. What would you say to encourage young people to actually pursue this field?
Well, first of all, they should understand it's a big commitment. Dental school has become an extremely expensive endeavor. They have to be sure that this is what they really want. But dentistry is a fantastic field, unlike any other, because there's so many different facets to it that you have to know something about. You have to know something about biology, something about materials. It's half art and half science. It's very rewarding. As I mentioned, the best thing for me is watching my patients come in year after year for their hygiene visits and watching the work that I did last in health. That's a great feeling. That's a very rewarding feeling, knowing that you helped somebody. I had a close relationship with my patients. I would say that if all they're interested is in is income, business is a much better and easier route. This is not the right field to go into. But if you are truly interested in helping people and making a difference and doing something that you get to put your own artistry into it, I think dentistry is a fantastic field. And there are many different areas of dentistry that you could go into that are all equally fascinating. And it's an endless source of fascination and learning. I've taken so many courses. I was told to keep a running list of courses in the 80s. And that running list is over 60 pages of courses that I've taken and given. And I never get tired of it. So I'm still involved in my profession after all these years. And that's something that a lot of people can't say if they're in a job that's not interesting or repetitive. This is something that will always hold your interest because it becomes a hobby as well as your profession. And I think that's really fantastic. And so I think it's a great field, but you have to really make a serious commitment and be sure that you're willing to follow through on whatever you have to do to get there.
I'm going to do a bonus question onto the last word because normally we stop it right there, but it just crossed my mind. How many years of schooling is also attached on? Because, somebody who may want to get into the field, when you're going into, medical or some sort of doctor program, or for a medical doctor, or even you going into law or things like that, you have a lot of extra years that are added on. As far as dentistry, are you dealing with additional 4 or 6 years of school that you have to add on?
Yes, you are looking at least, you're after college. Dental school is generally 4 years. I did college in 3 years, and then dental school. I mean, they had this crazy 3-year program, and I was a dentist at 24, which is very hard to do now. And then if you want to go to specialty school, like oral surgery school or orthodontics or endodontics, that's an additional 2 years. But really, my education began the day I graduated, and I had the best mentor that you could have. My dad was my teacher, and he lined up all these full mouth cases for me to do in my first year of practice. And he was going to check every step, and the patients were going to pay next to nothing. And my very first case, I had to prepare 32 teeth on this patient. And that case lasted for many, many years. But I ended up losing the patient because his son became a dentist. And but he called me up after 20 years to let me know he was very happy. And he still had my dentistry.
Wow.
Your education begins the day you graduate. So the best advice is, after you're done with your schooling, to find a mentor like what I had, somebody who will take you under their wing and show you how to do everything and explain how the best way to manage a practice. These are things that are not taught in dental school. That has to come later afterwards. So if you could find somebody that will help you, because your skills are very rudimentary when you graduate, they don't teach you a whole lot. And so it's up to you as a new practitioner to continue your education. You are responsible for your own education. And that's the reality.
Awesome. Dr. Feinberg, thank you so much for spending time with us and sharing all this wonderful information that you shared with us today. We definitely appreciate you spending time with us today here.
Thank you. It's been a pleasure.
Manspace Nation, we will be back with another episode next week. Until then, we are out of here.
No gimmicks, just game that my sure in sight. They shine like the city on a Friday night. Man talk, real talk, that's the way that you bless. Giving knowledge and some laughs in the same finesse. From life goes to the jokes that hit. They the tag team champs, yeah, legit with the wit. So pull up a chair, let the stress digest. From the beat drops, you know the rest. You go chillin' with Russ and Les.